Is a 68-year-old female, Caucasian, with a family history negative for GI neoplasms. She's a non-smoker, does not consume alcohol, and does not have diabetes. She presented to us with a weight loss of 9 kilograms in 6 months, and in December of 2013 presented with abdominal pain that was not responsive to analgesic therapy with paracetamol and codeine. In March of 2014, we tested her serum markers of carcinoembryonic antigen and cancer antigen 19-9, which were both elevated. CT scan showed nodules, suspicious nodules in the pulmonary and liver parenchyma, a hypodense formation in the pancreatic body infiltrating the splenic artery and vein that was not clearly separable from the gastric walls, and determined an upstream dilation of the main pancreatic duct. We also observed the presence of pathological celiac lymph nodes. Endoscopic ultrasound with fine needle aspiration showed the presence of dishomogeneous focal solid lesion of the pancreatic body with an upstream dilation of the pancreatic duct. There was thrombosis of the splenic vein from the portal confluence with splenic artery involvement, and fine needle aspiration of multiple lymph nodes of the celiac trunk and hepatic hilum were performed that determined positive cytology for adenocarcinoma. Today, this patient will undergo an endoscopic ultrasound with neurolysis by Dr. Sahai and Dr. Boris.
So this is an interesting but sad case of a fairly young lady. She really doesn't look 67 anyway. She looks quite young. With an inoperable pancreatic cancer. And so I'll just show you the lesion itself. For this, I go into the stomach just through the GE junction, and I find the liver, okay, right here. And then I look for the portal vein in the liver, and then I torque with my left arm. And again, you do all the torquing with one arm. You don't need to have your right hand doing the torquing. Turn your shoulders, okay? Hold on, I lost it a bit. Okay, so the vein is here. There we go, and it's gonna come out over here. There we go. There's the vein right there. Yeah, that's okay. And then here's the confluence. This is the pancreas. Here's the normal pancreatic duct. I'll show you a little better. There's the normal pancreatic duct right here. So if I follow this out to the tail, then you will begin to see this large mass here. This is the tumor, and we did see at some point. She has a little bit of ascites right here. I'm not showing it too well, but she does have signs of early carcinomatosis with the ascites. Let me see if I can show it to you a little better. I don't want to spend too much time on that. Okay, but then we'll follow. So I'm not seeing ascites too well, but we did see it earlier quite nicely. Okay, so then here's the mass, and then we follow the mass out, okay, and you can see the obstructed pancreatic duct coming out of the tumor. That's a very specific sign for pancreatic cancer. Sorry, here's the duct down here, okay. And then the other thing to look for in terms of inoperability is involvement of the celiac axis. Here's the aorta here, here's the celiac, and if there's any involvement near the bifurcation, that's inoperable. And you can see the celiac splits into two branches. Here's the splenic artery, and here's the hepatic artery. And see how the hepatic artery sort of disappears and then becomes very close to the mass. Mm-hmm. So there's hepatic artery involvement here, which makes her inoperable. So in these patients, in our unit, if they are inoperable at the time of EUS, and the surgeon agrees, then we do a neurolysis immediately. I don't know, Erwan, if you do it this way. But we published a randomized trial in the Journal of Oncology showing that if you do the neurolysis early, so in our patients, we randomized 100 patients. They came for EUS, and if they had any pain, even if they were not taking any medication for the pain, we randomized them to neurolysis immediately versus standard therapy with no neurolysis. And we found that first of all, the survival of all the patients was very poor, but in the neurolysis group compared to control group, their morphine use stayed very flat, but their pain scores were always better at 1 month and 3 months, whereas in the control group, their morphine use went up all the time, and their pain scores went up. And even in the patients who ended up getting chemoradiation or chemotherapy, even at 3 months, there was a benefit for the neurolysis group. So we believe that neurolysis really does help these patients. I don't know what you think. Do you find it works?
I think the same, because earlier you made neurolysis better is the efficacy of the treatment, because if you wait too long time, probably it's not, the pain is not due only to the infiltration of the nerves, but also of the of the carcinomatosis and due to the mass and so on. And so the efficacy of neurolysis is less if you wait too more time.
In some meetings I go to, I do hear people saying that they don't believe neurolysis works, but I think there are at least 2 randomized placebo-controlled trials showing that for EUS guided neurolysis, it really does appear to work. So I think the data are there. The next question is, what technique do you use? And I know there's some interest in injecting the ganglia. Personally, I think you can see some ganglia maybe here, or this may be a node. I think it's important to remember that you can't always see the ganglia. I think there are a few small things here and there. To me, these very small ganglia, it's very hard to precisely inject into these ganglia. And if you're injecting, 10 or 20 cc's of what we use as absolute alcohol, in my opinion, it's a bit of a waste of time to try and inject into individual ganglia. We prefer just in doing a bilateral approach where we find the celiac axis, then we turn to the side, and then we inject deeply down to the base of where the SMA should be. And we may go through some ganglia because sometimes you can't see them. And we distribute the drug all the way here on one side. Then we come back, and then we go on the other side, right about here, and we inject more drug here. And then we inject more at the base here. The other thing I do is I put the alcohol first. I think I'm the only person to put the alcohol first because I think it's important to get the concentrated alcohol on the ganglia before diluting it with the bupivacaine. And I don't think the bupivacaine, which we put at the end, even really makes a difference for pain relief. Usually by the time the patients get to the recovery room, they feel okay. So we'll start with the neurolysis. I'll take the first, I take a regular 19-gauge needle.
That's a very unusual, can I ask you about that?
Yeah.
That's quite an unusual approach, because if you give the alcohol and you lose your image because of the necrosis of the fat, how do you know where to put the bupivacaine?
Yeah, there's a bit of a blush for a couple of seconds, but it goes away. If you just have to be patient, it was a little bit bent.
And you begin.
Does everybody else do that in the audience? Hands up, people who put bupivacaine first and then alcohol. Hands up. Come on, let's have some interaction. Hands up, and hands up who put alcohol first.
Okay, so the problem here.
You're the only one. You are alone, Sahai.
Yes, I know. I'm used to that. Okay, so there's the needle. Sometimes the needle doesn't come out over the elevator. Okay, so you just have to sort of put your tip down.
Do you preload the needle with?
Yes. No, it's preloaded with alcohol.
With saline rather than having a stiletto.
Well, again, I don't see any point in putting the saline because I want to get concentrated alcohol. So I preload right away with the alcohol. So the first thing that hits the ganglia is pure concentrated alcohol. So here I am at the base. There's the needle. You can see the needle tip right here. Okay. So if the celiac is very close to the wall, you can always turn away a bit just to get through the wall. Okay. Puncturing through the wall a bit. You get through the wall. Okay, now I'm through the wall. Now I'm back at the base here. Okay, I'm going to put my thing here. Okay, so I'm turning to the side. Then I'm going to go deep here. Okay. And then I'm going to ask to aspirate. Yes. You want to aspirate to make sure there's no blood. Mm-hmm. And it's a good aspiration, and that's good. And the other advantage of the 19 is that when you aspirate, when you're in a blood vessel, you know it right away. Anyway, so now you can inject.
And you begin always on the left side.
Yes. I think most of the ganglia are on the left side. And then I sort of withdraw generally back here. There we go. If they get pain, that's usually a good sign. But she's under propofol. So now I'm back at the base. He's going to put... no. Attends, wait. So I come back to the base. Okay, so I'm at the base here. And so I've done this side. Now I'm going to do the other side. Okay, so I'm just going to inject at the base here. Okay, he's going to aspirate. Yes. Okay, good. Okay, so he can inject now. And again, the more pain they have when you're injecting, the better it is. But again, she's not having any pain. She's totally gone. Okay. Very good. And then now, okay, now he's going to put the bupivacaine. Okay, and I'm going to come back to the base. And what's good now is that there's still some alcohol in the system. So when he pushes the bupivacaine, he's going to still push some alcohol here at the base. Okay, so you can aspirate again. And probably the most dangerous part of this is actually bupivacaine, because if you inject the bupivacaine into the blood vessels, that could actually, I think, cause some arrhythmias and stuff. Okay, so go ahead, inject. So I just stay here at the base. Okay, good. Very good. So it's kind of a V shape.
What's your feeling about if the patient is fortunate to have 3 or 6 months survival and pain recurs? What's your feeling about doing it again?
You can certainly do it again. Is that keep going all the way? Yeah, you can do it again, and I don't know if there are any data looking at the success. It works. I think it does work. Yeah. The problem is we don't have any control data, but yeah, I believe so. I really believe so. Okay. So I think the key elements, and then out we go with the needle. I do like to just do a little Doppler to make sure the celiac is still functioning. Although, even if it wasn't, what could I do? But it's just, you know, it's a very safe procedure. You know, in the randomized trial, we had 100 patients, no complications. We've done about 1,000 now. We had one death from a sort of a wide thrombosis of several arteries, the celiac axis, the right renal. It was a very strange case in a lady who actually wasn't clearly a cancer patient. But since then, I'm always felt a little concerned about doing this. There's only 1 or 2 other cases of vascular thrombosis described, but you have to keep that in mind. You know, the more we do of this, the more there will be complications. But overall, it's an extremely safe procedure, and I do believe it's effective. Are there any questions? Or
Do you keep the patient at your hospital one night, 1 hour?
Yeah,
how many
no,
times?
we send everybody home the same day. We don't even give any specific orders about giving them saline or the low blood pressure. All our patients have low blood pressure after an EUS, so we've never really noticed that. You have to tell them that they may get some diarrhea for a couple of days after the procedure. We don't give them antibiotics, so you know the diarrhea is not because of the antibiotics. And in fact, for many of those patients, I think who they're constipated because of the narcotics, it makes them feel a little better, actually.
Just a question about the type of needle. If you're doing a combined procedure, you're using a 19 gauge. I'm not sure if you're using a EUROEUS needle or
no, it's a regular
FNA
19.
And if you 19 gauge, but if you're doing it as a 22 gauge needle, does that make any difference? Because if you
well, the reason I use the 19.
Diagnosis, do you reuse the same needle?
Well, I mean, if you want to save some money, you could use the same needle for the FNA as the neurolysis. Because we use a 25 for FNA, so that's why it would be very hard to inject with a 25. You can do it, but I'm far too impatient. So, and I like the 19 because it injects much more easily, especially if you're ever using steroids for celiac plexus block, which is a whole different story. That makes life much easier. And as I say, when you're in a vessel with the 19, you know it right away. So we just tend to always use the 19. I don't think there's any particular advantage for using the CPN
you
needle.
Use the neurolysis needle.
I don't think there's any advantage to that because it's a 23 gauge needle. It's not quite as sharp as a 19. And if you look at when you're, you know, because we're distributing ourselves the drug very widely by going in a bilateral position, you don't need that spray. And if you just take that needle outside the patient and inject fluid, you'll see it doesn't spray out really. It sort of just dribbles out. So you're not really getting an advantage, I think, by using that needle. I think the important thing is to just be able to, you physically take the tip of the needle and distribute it very widely on both sides of the celiac axis. I think that's the most important thing.